Women make up 70% of the healthcare workforce, but only 20% of its leadership. On Her Story, we'll explore the careers of bold and influential women from Silicon Valley to Capitol Hill and learn how they've overcome the odds. I'm your host, Angela Jane, and this is Her Story, a program where we explore what's beyond the glass ceiling. Well, today I'm delighted to welcome the CommonSpirit Strategic Innovation team. It's going to be a special edition where we have the dynamic trio behind one of the largest health systems in the country's innovation efforts. So I'd like to welcome Christine, Anu, and Manoja. Welcome, ladies.
Thank you so much. Great to be here.
Why don't we start with just some brief introductions? So Christine, I'll kick it over to you to tell us a little bit about kind of what you do at CommonSpirit.
Wonderful. Thank you, Sanjala, for having us. And I've really enjoyed listening to some of the previous episodes and excited to talk a little bit about what we do. I'm Christine Brocato, System Vice President for Strategic Innovation. I focus on external partnerships, mostly with technology and services companies. Some of the specific categories that I focus on are population health, health equity, behavioral health, and new care models. When we think about partnerships, we are at the front end of that. And so as we evaluate partnerships, we're usually on the front end of monitoring trends, finding the companies, performing the diligence, negotiating the contract, and then ultimately looking to incubate the solution in our organization and understand if it's a fit. Let me see, what else about me? So I'm a career healthcare person. So I've been in healthcare my entire career. And I've been on several different sides of the industry, from medical device and biotech to the provider and payer space.
Wonderful. Well, excited to dig more into that momentarily. Let's kick it over to Manoja to introduce herself.
Thanks, Angela. I'm happy to be here too. So I'm Manoja Lecamwasam, part of the Strategic Innovation team, and I'm responsible for intellectual property at CommonSpirit Health. And we look at that as the internal innovation of our employees and stakeholders, and also life sciences innovation that is either external or internal. By training, I'm a molecular microbiologist, but I have been doing innovation and tech transfer and intellectual property management in academic medical centers and in community hospital systems.
Great to have you. And last but not least, I guess the newest member of the team, Anu.
Hi, thank you for having us, Angela. We're very excited to not only share our stories, but the story of our team, which I think is going to be a lot of fun. So I'm Anuradhika. I'm part of the Strategic Innovation team, along with Christine and Manoja. And much like Christine shared, I also manage our external partnerships with a lot of innovative companies out there, focusing especially on the verticals of alternate care settings and remote patient monitoring technologies and insure tech and personalized care models. So really excited to be here and eager to dig in.
Wonderful. So I think, one of the things I was most excited and why I wanted all three of you to come together was that really innovation is such a, it's a big lift, and it means a lot of things to a lot of different people. And I think your team dynamic is really just something to be admired by others, because you're really well integrated, but bring in a lot of different perspectives and viewpoints, which I think makes it kind of a stronger team. So I think it would be interesting to first start with, how do you all kind of think about, let's call it like the charter or kind of key objectives of the strategic innovation group within the health system?
So as we talked about, we like to challenge the status quo and look at how we can improve access to care and offer new avenues to grow and to serve. And especially in this rapidly changing healthcare environment. But we strongly believe that successful innovation depends on our ability to build and form partnerships and coalitions and cross-industry collaborations. But for innovation to be successful, we need to overcome systemic barriers to care, such as health disparities due to social determinants of health and issues with access to care, by marrying social community services with medical care, and to find innovative ways of how we can do that. And along that line, we also like to think about how can we serve each person in a more personalized manner and move away from the one-shop-stop mentality. And this is not just looking at it from sort of a genomic, proteomic perspective, but on really how do you personalize the care. But I think most of all, what's interesting about all of us, and I think a common theme for all of us, is to look at 3 to 5 years ahead and see where the industry is going and where we think our organization is going. And then to see if we can bring in capabilities in today. And some of these might not be ready to where it needs to be, but can we work with these technologies and companies to build what we want in the future so that we are ahead of the change? And I think that's a common theme in a lot of the innovation work that we do.
Let's make that really real. So you all are evaluating different technologies or innovations out there in the market. Where do you start? Like what does the process of diligence and market research really look like to getting it to the point where it's truly integrated into the DNA of the system?
I think of it like it's like a recipe. It's kind of like one part this, one part that in a specific sequence. And if you can get that all right, then we're likely, building a successful partnership. And so, as Manoja talked about, like first is getting ahead of the trend and really thinking through where is the market going? Where do our patients want to be? What's their preference? And understanding kind of where we need to be and pulling that in. And so if we can pull that in, 3 to 5 years ahead of time and start to incubate that, that's the first part. I think the second part is really thinking through who might be a good partner. There are so many fantastic emerging companies out there. And so for us, it's about really having the discipline to understand if it's a right fit for us. And it's not just about the product, it's also the fit with the leadership team and can they work with a company like CommonSpirit? And then I would say a big piece of it is defining the goals. Right up front, really understanding the success metrics that we want to move and getting a lot of alignment, not just internally, but with the partner to say, listen, we're probably going to look at every data point under the sun. We all love data, but there's got to be 3 that means success of this pilot to be able to move forward. And we need to understand what hurdle rates that we're going to meet with each of these metrics to move forward. And I think that's a really critical part. And if you miss that part, things can get messy, towards the middle and the end. So we spend a lot of time really trying to define that success. And I think the last part, which is critical, is finding the right operational leader and making sure that person is with us from the very beginning as we kind of get through the process, so that when we're in pilot or incubation mode, there's this nice handoff where we can start to step away and they can start to really claim ownership of the program. And success for us is when we see leaders at big meetings saying, this is my project, this is mine, and we're like, nice for us to go. But that is success when it's baked into the DNA of the company. That's a success for us.
And I think just to tag on to that, Sanjala, where we take great pride as a team is to just serve that connective tissue, right? So we want to make sure that when we are partnering with companies, we are able to really help them understand the ever-changing and very complicated at times, the healthcare environment, the regulations and all those things. But on the other hand, internally, we are able to really bring these ideas as potential solutions to operational leaders who are, living with the consequences of something which is not efficient or having these gaps in operational opportunities. And so for us, being that connective thread who can translate the language of the external ecosystem to the internal operations and have the operations and feel the ownership of the solution and could run with it is really the sweetest spot. And that's what we take the greatest pride in. And when both the parties feel like they were able to meet each other in the middle and we were able to make that transition seamless for both the parties.
You both are making it sound so easy. So let's kind of play that out a little bit further. So, I think CommonSpirit really has been a leader in the provider market in particular. You guys have partnered with groups like Lyft, to behavioral health companies, to social services companies. I mean, you kind of the full gamut. So what does the process actually look like in terms of how the three of you work together in your respective teams from the time of, sourcing a partner, potential partner, and then actually bringing them into the organization? So I think Unite Us, for example, or Concert Health, I know these are, two organizations that you're working closely with. Maybe walk us through an example of kind of how the three of you have worked together to kind of work through one of those partnerships.
Over time, what's nice is that we're all kind of building different types of expertise, so that, I know when something falls into home health, for example, I'd be going to Anu to say, how do I think through this? Or are you going to take this through? And I will support you. So we've kind of built that, those functional areas, and it's kind of just happened organically. It's a function of the projects we've taken on, and we've built the expertise, but also the passion areas that we bring to bear because of our personal experiences with health. The Concert Health project was fascinating because that really came from the markets. We're usually on the streets, meaning like we're talking to our clinicians on the ground floor level. And we had PCPs telling us, listen, I'm seeing, this was before COVID, I am seeing increases in mild to moderate depression and anxiety in my panel. And usually there's about 3 people I can refer to in the community that I feel comfortable with. And when that doesn't happen, I start to take it on as a good doctor. I start to try to spend a little bit more time, understand why they're not coping. And we knew we needed to do something because our doctors are working with physicians or patients in that way anyways. So we started to assemble an internal team to say, what would we do to address that? How do we really think about addressing these spikes in depression and anxiety? But how do we also take the burden off of our staff? And the PCPs are like, listen, if you bring an app to me, I will kill you. Make me log on, it is not happening. And so I think, the feedback was incredibly strong and consistent. And then, we started to formulate an internal team to say, let's evaluate that. And that's when we really started to realize, this collaborative care model where the PCP is still remaining at the forefront of the care, but working with the therapist and looking to treat a patient holistically. That's what we want to do. We want to unburden the PCP, but also recognize that she wants to stay at the center of the care too. And so that model made sense from a flow perspective, and it made sense from an economic perspective because there are reimbursement codes for collaborative care. So instead of paying $150 to go to a traditional therapist, it's just your copay because you're there at the visit anyways. And so all of those parts started to come together. And then we went out to find a partner that would be a good fit for us. And there's a lot of fantastic organizations practicing collaborative care. There's a lot of health systems that do their own program. But for us, what really made sense with Concert is collaborative care is all they do. They know it inside and out. And we knew that that's the type of bench strength that we needed. We needed therapists who could answer the call, could be flexible, English and Spanish. And so that started to really, the diligence started to prove that not only were they, had the right model, but I think in terms of a leadership team, they were willing to almost teach us how to do collaborative care the right way. So all those pieces started to come together for the partnership, and we've been really excited. I was looking at the data the other day, and for the patients who use the program, 80% have never received mental health care before.
Wow.
That means it's the first time. And I think it's because it's either, probably 2 reasons. One is their PCP is saying, hey, sounds like you're having trouble coping. Why don't you talk to my, associate here and she can kind of help you unpack what you're feeling. So it's this nice validated handoff. The patient just has to say, sure, and pick up the phone. And I think, you know, that's part of it. And the other part of it is COVID and maybe people realizing issues that they hadn't had before as a result of what we're experiencing. So it's been pretty, it's been well-timed, and we're just super excited about the data we're seeing.
So if I hear you correctly, you know, a lot of the processes then basically identifying the market need, kind of like laying out what those core objectives that you're trying to solve for is, finding potential partners that could have fit that bow, kind of narrowing it down. From there, then you're now, you know, tracking these metrics to see how it's working. You know, I think there's this lingo in the industry around like death by pilot, right? And so CommonSpirit, you guys deliver and touch patients, you know, what, more than 20 states, if I get those numbers correctly, right? Yeah, 21. So where do you go from there? Like, what's the process of actually, you know, scaling it across different markets, or selecting which markets are actually the best fit for it so that it's actually touching, you know, a broader group of patients, or, you know, getting your clinicians on board? What's kind of the downstream things that you're thinking about across the team?
So this happens a lot, Sanjala, where I think, going back to your question of how do we know, it's just the divide and conquering that happens organically all day long between the three of us. And so I think once, you know, we do believe that if the pilots stay with innovation or in that piloting phase for a long time, it doesn't let the solution really shine and become what it could be. And so we are very diligent, right? When we think about the piloting, Christine mentioned on how we are very sure going into it, what we'll be tracking, what data we'll be measuring, what are the potential success factors. So for us, a pilot is more of like an exploration of how those data pans roll out. It's not, you know, a surprise of like, hey, let's just start the pilot and we'll see how it falls. So we are very diligent in how we plan the pilot and the operational support around it. So what happens organically is that by the time something is getting to that mature phase in the piloting, we already are getting a lot of interest from the other markets because they've heard about the solution, they've heard about the impact. So just to take an example of the maternal child health program, Dosent Health, that we launched early in the pilot phase, the impact to the mothers, right? And the impact on the length of stay, the NICU volumes, the care the mothers were getting, the patient engagement was so immense that we saw markets actually reaching out to say, hey, that pilot is happening in California. When can I have it in my state, and where could I go from it? So there's a lot of organic traction that happens in the pilot phase, and that lets get you the involvement from the right clinicians, right stakeholders. If it's a population health initiative, get them involved, and make sure that we are thinking about the expansion from an IT angle, an integration angle, a patient reach out, communication angle. So that was all being done methodically in parallel as the pilot is getting to that maturity. And so once we are at that side where the results are in and the impact is pretty visible, then it's all about taking it and scaling it as rampant as possible, so majority of our patient populations could benefit from that solution.
Also, what's really important is, as we're doing it, to keep in constant communication and share the successes and share the results with the organization, so that you don't do a pilot for 6 months and then do it, right? You sort of tell people you're doing the pilot, have some moments when you discuss with the clinicians and the operators about how it's going, so that people are aware of it. And if it's successful, then you already have people who know about it. And we also don't try to pilot in one place that's geographically the same. We try to look at different places to set up our pilots so that you get information more holistically about how a company or a technology would fit a certain population or a certain state, and not necessarily the same result comes from doing it somewhere else. And so I think it's just keep making sure that your network knows internally about what's going on. And the last piece I would say is, when you're negotiating for a pilot, we also try to see if we could look at a larger agreement, so that if the pilot is successful, then you don't have to negotiate every single place on a case-by-case or a site-by-site basis. You already have a template, and then you can just add on the interested people, which is just a very operational agreement kind of a thing, but that could take a long time. I think those are some of the best practices we try to include when we do this work.
And Manoja, you said this earlier, but really what you're doing is challenging the status quo, which is not easy. And, that's what you're doing day in and day out. What are some of the challenges or the most difficult aspects of, making these changes and bringing people along both internally and externally?
I think it's really interesting when you're looking at something that comes down the road, right? You believe that something is going to really be important in 5 years because the science is there or the evidence is there. But today people are dealing in healthcare issues that matter to them at this moment that's all consuming. There's so many things that needed to get done, so much money that's needed to take care of things that are happening day to day today, that to take money or resources or attention away from those things to plan for something in the future is difficult. It's difficult in any industry. And so one of the biggest challenges that we have is to go to our operators and our clinicians and say, look at this technology, this looks really interesting, the future is here. How do we, while you're completely overwhelmed or enveloped in what you're doing right now, start to think about how we can look at this technology to help something that's happening to you right now, so that as we start to build that foundation, we'll be ready when it's being used a lot more. And I'll take precision medicine, for example, right? If you look at precision medicine, it's very well established in academic centers, sort of, through research and the work that's done. But I think for precision medicine or personalized medicine to be really successful, it needs to be in the communities because care happens in the communities. But for a community physician, they don't have the time to sit and look at the science and go through all the articles and know what's right and what's evidence-based. And so if you ask someone in a community, you'll say that precision medicine is not right for prime time. But if we don't build the infrastructure and we don't invest today and we don't look at how it could be used in the future, then when the time is right, we will be behind the 8 ball. And it's going to take a lot more time to build it up. And so it's the effort that you have to put in today to something that is in the future, but do it in such a way or educate people in such a way that we can see the big picture. So that's the education part is one component, but then to work with all of the resources around you, sort of philanthropy and grants and funding, to really do something today as an example so that those results are there, off of which you can piggyback when you really need to implement it within the organization.
The challenge is both systemic, but also personal. And so, when we talk about health systems, they were built to not have risk. They are built to be completely stable. And we are in the business of saving lives. So there's a lot of structure so that whole thing could be incredibly predictable, stable, and not have any risk and not change. And then here we come along and we are in the business of driving change. And so there's a natural friction of really kind of, the systemic nature of what we're in. And unlike other industries that have like dedicated R&D departments, health systems don't have that. The innovation functions like R&D. But I would also say that we are also trying to change kind of individual hearts and minds of decision makers, and everyone can reach a decision to change for different reasons and different motivations. And finding out those pieces, often takes time. Some people are, show me the bottom line type of people. Some people are like, I just care about the quality scores type of people. And then there's still others who, need to know that it's been, super validated by, half of healthcare before they want to act. And so there's different points to that. But I think, at the end of the day, it's our work to really set the vision and try to capture why we would want to introduce this change, because I think we're all unified by sincerely wanting to provide a patient with a better experience. That's the one thing we all have in common. And if we can connect to that, that's where we start. And then to get to the big yes, we start with really small yeses. You know, can you take a meeting? Would you look at the data? Would you consider a demo? And I think if you start to get to some of the little yeses, they can build up to ultimately the bigger yes, which is, I want to be the sponsor. I want to own this. So it's a process, it's a small process, and it's different every single time.
That's very well said. I mean, inherent in what you and Manoja are talking about, Christine, is actually a really big tension in the industry that we're seeing. And I know we're going to talk about your respective backgrounds, kind of pre-health system days in a minute, but you know, this whole idea of pace of change, let's call it, where you've got all this innovation, scientific discovery, technology, these new companies, and then what I'll call more of the established players like the traditional health system model, but also the regulatory environment and the reimbursement schemes, right? They're kind of at odds with each other. And so I think what's always stood out to me for systems like, you know, CommonSpirit and the work that you all are leading is you're kind of trying to bridge those two worlds together and have, you know, them meet each other somewhere in the middle, maybe. But how do you, I mean, what is it about the culture of the organization or how you're viewing the landscape where you're able to kind of overcome that kind of inherent systemic barrier, if you will, where it's not that easy for to innovate, so to speak, within a health system environment if you really look, you know, culturally what's been ingrained in how we think about healthcare?
I think regulation and the constraints, right, that exist in healthcare around privacy, patient data, preferences, we all have to acknowledge that they exist and they're not going to change anytime soon. And they exist for a reason. So I think for us, we start there with that acknowledgement. And then the job becomes not so much as to how do you fight those, it's more about how do you bring the innovators along to have that be the lens as they start creating solution. Because the most frustrating part, essentially, when you have a wonderful solution and you're down the road and you're much ahead, and then you realize, well, regulatory, you can't do this because of this constraint. So I think Manoja brought it up in the earlier conversation. We try really hard to pair up with them very early in that code development phase so we can actually guide and help them maneuver, be it compliance, be it legal, be it like, you know, IT, data, privacy, all of that, so that we are bringing that lens to them as they seek to change the status quo and they seek to like create innovative solutions for healthcare. And then it's early in the journey, but then also being by their side as they go through it time and again. Because what happens then in that process is they get to create solutions with that mindset, but more importantly, the organization gets to understand the solution in that different light. So you're, again, going back to the meeting of the minds, right? You're making sure that both the parties are able to see each other in that common spot where, you know, we are cutting down the barriers from the compliance side and the regulatory side for the innovators, and we are making our culture also come up and rise to the occasion when needed to know that I have to make XYZ adjustments or, you know, have to complement it in a certain way. And when they both come together, that's where the win happens. And we always acknowledge where healthcare is today, but we are also motivated by where we want it to be tomorrow. And so it's living between the two and making sure you're constantly going from point A to point B, even if it at a snail's pace, it's happening. The change is constantly happening.
I think another piece that you know, really underlies your effectiveness is this idea that, you know, if I can be so bold to say this, like the three of you don't really embody what I think stereotypically we perceive as the traditional, you know, head of innovation, right? So at least personally, you know, I think about innovation or the way that it's kind of described in the industry. It's like you're kind of the tech, Apple, Microsoft, you know, wonky, you know, computing, making an app world, or maybe you're highly clinical and you're coming up with some new therapy, right? And there's a lot of things in between that, but I think each of you bring a really unique vantage point perspective, kind of outside in, both from kind of the roles that you've held in the past, but then also kind of your personal upbringing and immigrant experiences and different things and how you view the world that kind of gives you a different lens on how you think about innovation. Talk a little bit about that. I mean, I know one thing the three of you have in common, which I think is so powerful, is that you grew up as immigrants. How has that shaped your lens towards healthcare?
It's actually really interesting when you come from a developing country, as an immigrant from a developing country, and you see the health disparities and the health inequities. But personally for me, my mother was the first woman from her village to go to medical school. And when she practiced medicine, she didn't see herself as a physician apart from who she was as a person. And so I remember going to the grocery store, and she was buying groceries for her patients who couldn't afford it, so that when they came in to the clinic the next day, she would have something. So she was looking at social determinants of health way before we thought about that in the developed world. But that is how medicine was practiced in the developing world, because you couldn't separate the care from where that person lived. And so I think when we look at innovation and when we look at health disparities and wanted to make sure that everyone has health equity, I think those experiences of seeing what health inequity really does to a society, and how even in little ways you can do your part to make it better. I think those are the motivations that allow you to look at the big picture, bring in new experiences, and even if you fail, to keep going. And so for me, at least, I think that every day coming in and knowing that there is a purpose, because whatever we do and we put in place is going to help a person who might not be able to help themselves without this service or this technology or this innovation that we are presenting. I think that makes all of those issues and the frustrations worth it, right? Because you need to have a purpose. And I think that's what is needed to do work like this in an industry that's resistant to change somewhat at this moment.
My parents came to this country. I'm the first American on either side of my family. My dad's from a rural side of a village in Spain, and my mom is from a really small island in the Philippines. And so, we came here to California, to Oakland, and ended up settling right outside of Oakland, in a small suburb. And it was a really diverse community. And even before I knew the term social determinants of health, I knew in my bones that if you were a person of color, that there was a chance that you were not getting the same access to healthcare, and that there were social factors. Before I had the words, I saw it in my friends and in my neighbors. And I think it drives a couple things in us. One, I think a lot of these terms get very academic.
Absolutely.
Social determinants of health was the phrase 2 years ago. That's poverty. And now I'm heartened that we're talking about, I'm heartened that this year we're all talking about health inequity. But I think, our backgrounds make that real, because when people talk about the Medicaid population, those were my neighbors. And so if I can't see it flying with them, then it doesn't, and so it kind of grounds us in the reality of who we're working for. And I think the other thing is it also creates a sense of, deep empathy for the challenges that people face, because we have experienced those personally, and have been in communities to see that play out.
That all resonates so much, and I think that's a shared fabric, right? We've all developed, or we've all lived our lives where the difference between the have and the have-nots has been really clear. Be it, Manoja coming from Sri Lanka, me from India, and Christine in her, exposure to the Oakland community. So for us, I think one very tactical way it manifests in our work is, Angela, making sure that any technology, any innovation that we're bringing is helping bridge that gap and not further it more. You see a lot of solutions where it's leveled on it's based on the assumption of high health literacy. It's based on the assumption of access to Wi-Fi. It's based on the assumption that people will have all these luxuries to make those decisions and access care differently. So for us, it's really important that when we are evaluating those solutions and those technologies, we are constantly looking at how this is going to help bridge that gap and not further it more. So that will be the only other addition that I think we all feel very strongly and very passionately about, is to do our 2 cents, do our job in connecting and bridging that gap.
I think that is so powerful. And I loved what you said about the kind of the shared fabric, because I think that just shows in the tremendous passion and kind of unity that you guys have as a team. And I think that really connects you and to do all that you do so well. I'm curious, do you guys have healthy debates or contentious debates internally amongst the trio on when you're, super riled up about something and you're like, oh no, we need to do it this way? What is that like?
I would say it's more like group therapy. There's a lot of group therapy. We have a team meeting every week, and it quickly devolves into a support group of sharing and trying to help each other and brainstorming together about, how do we figure out problems and work to overcome barriers.
Makes a lot of sense. So, you've all shared a little bit about kind of your lens of what shaped your kind of interest and influence in healthcare. I guess shifting gears a little bit then. So as you think about the leadership kind of dimension of it, so one of the fun questions we like to ask all of our guests is, as you think about your foray into healthcare leadership, and this could be kind of pre-CommonSpirit days, do you consider it to be more accidental or intentional in kind of the different roles that you've held? So really, what was the first time that you really viewed yourself as a leader, so to speak? So I don't know, maybe Anu, we'll start with you.
Yeah, I think for me, it's a combination of both. It was definitely intentional because growing up, I had a lot of passion for healthcare and medicine. And, I'm a clinical pharmacist by background, so I trained to be one. So that was definitely intentional. Everything that happened since then, I think, has been a combination of following my heart where, I wanted to go next, and B, being open to opportunities. So I went from being on the research side to starting my leadership journey on the business side, doing a lot of strategy, provider care teams, then being a part of the startup, and now in this innovation world. That has been a combination of just not being scared to take on something that was entirely new. The tactic that I follow is, if this something makes me really scared and anxious to take this on, then that's the right thing to do. So that's always been the driving force and the guiding one. And so I would say where I am today is probably a combination of being at the right time, having wonderful people who, helped me and showed me what other opportunities did exist. But my love for medicine, my desire to be in healthcare is very personal and was very intentional to begin with.
So my foray into healthcare is accidental, because I really thought I was going to be a bench scientist, doing research. It was a good accident. But once I got into healthcare, I would say that my leadership is intentional, because I think with leadership and a position of leadership, I think you have to be intentional about how you present your vision and your values, and how you help your team, and talk about what you want to do as a team. And so I think that part of it is definitely intentional, and I'm aware of how I am and what I need to do when I'm with my team.
I would say that I never in a million years thought I would be in healthcare innovation. You're the immigrant's kid, you get assigned one of three roles. You're either a doctor, a lawyer, or an accountant. And I was assigned doctor when I was about 5. But I didn't mind at all, because I knew in my heart that I wanted to affect people's health and well-being. I just had that feeling. And even in my diary, like I think the first word I spelled was nurse, but I accidentally spelled it noose. And I just kind of I just knew that I wanted to make an impact. And I think as I grew and matured and had more experiences, I realized that it wasn't going to be one-on-one, that it was going to be more macro. And so that landed me on the business side. So that whole part was accidental. And once I really started to see how technology and innovation could completely help scale healthcare for all sorts of populations. I think that was like when my heart exploded, and I was like, I just want to do more. I want to, influence more and do as much as I can in my career in this vein. So that part was very, very intentional.
And so I know this is a little bit of a loaded question, but at what point did you begin to realize that kind of the leadership career journey was going to be different because you were a woman?
It's interesting. When I was doing research and I was in the lab, I had a very, very supportive mentor. And this was not something that he told me. He had a lot of women in the lab. But someone told me that if you want to run a lab and you want to be a leader in research, then you better not get pregnant. Because if you get on the mommy track, then you are not going to be able to lead it. And interestingly, I had my baby when I was finishing my dissertation, doing my Ph.D. And I worked, and it was a tough endeavor. But I think saying and putting that into the universe and saying you can't do something because you're doing something that is biologically amazing, that you do as a human being, sets a reaction that I think we should start to avoid.
I didn't really notice the differences between men and women for much of my career. I looked around and thought, well, I'm getting promoted just as much as my male counterparts, and I'm making a difference just as much as them. And it wasn't until I became a mom where I thought that's where, I really started to see the difference. It's little things, in business, the pace can move really quickly. And if everyone decides to meet in Ohio tomorrow, most people are saying, what's the content? Who's going to take the presentation? But a working mom says, who's going to do the pickup and drop off? Oh my gosh, like who's going to miss something because I can't be here now. And so all those things come into play. And that was really eye-opening for me. I mean, as soon as I had a baby, I think I started to notice the change, and I'm like, oh my gosh, like everything I've heard is so true. I remember, being asked to interview, actually getting recruited from a company that I thought was so amazing. And I had just had a baby 6 months out, and they said, why don't you fly over and interview? And my husband was so supportive, and it was my first flight after having a baby. And here I was, like, finding the lactation room in the airport and then coming in for the interview. And what happened was because I had traveled, more and more people started to want to interview with me because they thought this was the one shot. I want to introduce myself, get to know Christine. And so the 3-hour interview that I had perfectly timed became a 4.5-hour interview. And by that time, I think my body was ready to explode. I felt cracks in the system, and they kept saying, Christine, do you want to use the bathroom? And I was like, no, I don't, because I think I'm going to die if I move right now. And so it was such a female experience that a man can't understand. And I think what I learned from that, because after I got the job and I was laughing and telling them about that experience, they said, we would have scheduled in a lactation break, like no problem, like any of us. And so it was really about me trying to, like, this perception that I had to hide my motherhood, that I couldn't be honest, that I had to do something so natural. And so I think my learning during COVID too is that, most people are more understanding. And it's really about me giving myself permission to have that balance.
That's really great advice. Thank you for sharing that. If I could just piggyback on that for a second, I know Manoja, you're celebrating actually 2 graduations, I hear, of 2 of your children, which is very exciting. You must be a very proud mom. But, what advice would you have for other, mothers who are juggling a demanding career and a family?
I want to start off from the position of leadership, when you can make change, how important it is, because I think it's really, I hear people say, you leave your family and your life at home, and when you come into work, you need to concentrate on work. I'm of the outlook that a human being or a person is life and work. And just because you're there, let's say in a job 9 to 5, doesn't mean that all of the other stresses and the pressures that happen with your children and your husbands and your sick parents, whatever, doesn't influence what you're doing in the office, right? And it could even be distracting you because you're worried and trying to do something. And so instead of saying, how do you sort of keep these things really separate? How do you try to be a more empathetic leader or someone who's aware of what's happening and try to have flexibility in a schedule so that if you can do what you need to do as a human in life, then I think that translates into you doing what you need to do as a human in work much better. And one of the examples was, so as I said, I had my oldest daughter when I was finishing my dissertation. I was in a very new job. It was a very structured, strict job. And I tell you, everyone has their kindergarten activities at 11 o'clock in the afternoon or at 1 o'clock. And for a working mother, if you're living far away from your daycare, going back and forth, those things are very difficult things to do. And my husband was a busy person at that time because he was training as well. And our daughter was the only one probably in kindergarten that had many occasions when there was no parent, because it's not because we didn't want to, but it was because we couldn't make it. And in that moment when I was supposed to be there, my heart was breaking at work because I couldn't be there, right? And at that moment, I think what I thought is if I ever had an opportunity to make a difference or was in a position where I could influence how my team or people that worked with were behaving at work, that we would look at how we could introduce flexibility so that not just women, but also men could be there for some of these occasions. And if some of the men could take time off and go for one of these occasions or these child activities, then the women don't have to make that choice every single time. That we get to share this and really be there for our children and tag team and do it. And so I think it wasn't easy, but I think you do the best you can, and then you make the changes that you want to see whenever the opportunity comes up.
Absolutely. I mean, I think that's one of the underlying reasons we started this show. Her story was that we wanted to share these stories of what women leaders at all different stages of their career are kind of experiencing, because these are things that we don't really talk about at the point in time. Christine, a little bit to your example about, maybe asking to take a lactation break. And so how do we kind of build this culture where others, both men and women, are, understanding the breadth of these challenges so that we can make these systemic changes to kind of accommodate it. Anu, didn't want to overlook you there, but how about you? At what point did you realize that your kind of career journey was going to be different because you were a woman?
My mom, I always had a working mom, right? So we come from a very remote part in India, and actually my mother's journey, I think, really shaped the woman I became because, at 18, in a typical Indian fashion, she was supposed to get married, right? And she defied all that. And she said, I'm not marrying. She went, became the first girl in the entire state to get her master's degree. Didn't stop there, got another one, did not marry until much later in life, and was a working woman all her life, right? So, but I used to see her get up at 5, cook breakfast for the entire family, the in-laws included, come back, get immediately into the kitchen, be there until 11, doing all that. And at that time, looking her do all that, I thought, that's not going to be my life, right? I'm supposed to take it to the next level. So I'm going to really challenge the status quo. So when I started working and I became a mother, it was very eye-opening to me that I was falling in the same pattern. I was doing the same things that my mother did. I was carrying all the weight alone, right? Wanting to get up, having to be a perfect mother, cook like a perfect meal, go to work, put in 10 hours, come back home, do it all. So for me, I think the big realization was that if I do really want equality at work, and if I really wanted to be changing for women, I have to start at home first. And so it was a very honest conversation with my husband to say, how are we going to do this? And where can I take the lead and where he takes the lead? And Sanjala, giving myself the permission to do that at home actually made me a much better leader, because then I could walk into the workspace and really look at new eyes with what was the divide and conquer that was happening between men and women, and also how to challenge it for many other to come, right? If you're not in that place yourself, it's very hard to say, where do you want to change for the rest of your team, as Manoja said, being really cognizant of like the women in my team or on my team are not compromising on their personal and professional life. They can truly have it all. And to also give ourselves permission that we have the right to ask for that equality, be it at home, be it at workplace. So I felt like my journey started with being really that rebel of like questioning it, right? Like, you know, women have been in workforce for what, 70 plus years now. If you think that World War II was when we really started joining, to getting, it's taken too long, it won't. And then realizing that I'm actually becoming a part of the problem myself, doing the same things. And that was a wake up call to really drastically change how I conducted myself and engaged both at work and, you know, at home. And I do believe in the process. I made my husband also a better professional, because, you know, doing his equal part at home actually enables him to go with those eyes and with those lenses into his workplace, you know, and make sure that the women on his team are also feeling supported, and he recognizes where they come from and the pressures they are under. And, you know, as a support, as a leader, he can make sure that he's there for them and stand up for them. So I think it's a combination of both, calling our supporters into play and also taking the charge where we need to.
That's leadership. I mean, I think the common theme with all three of you is you're challenging the status quo, not just professionally, but personally too, to really, you know, make these little but mighty changes. And I think that's really so powerful. So I guess, you know, thinking about the status quo then, is there a piece of advice or kind of some kind of philosophy that you believed early on in your career that you no longer believe to be true?
I'm a strong believer of, as Anu and Christine have said, you know, I have a very supportive husband too, and we sort of, you know, really talk about sharing chores and doing it together. And at the beginning, I was always about, you know, 50-50. You know, the way to a successful career and a way to be successful at work and also have a successful family life is to be able to do 50-50. And I think with time, what I realized is I was looking for an average of 50-50. Because there were moments when I was 10 and 90 and my husband was vice versa, right? And if when we looked at the times when we were doing all this work, we ended up averaging 50-50. And we both felt like we were going in the right direction and being fulfilled in what we were doing, and our kids and our families, when needed, you know, had us. I think that would be okay. So now, instead of constantly trying to find, did he do this exactly? And is this job 50-50? I try to look at the average. And that has actually helped me sort of less stressed and be able to look at the big picture and feel good about where things are going.
That really resonates as a researcher who loves thinking about numbers and averages. So I really, that's a great little tidbit to keep in mind.
For me, it's about not striving for the A. Mm-hmm. And when you're raised to achieve and to be a straight A student, that really does not translate well in the workplace. And I think, you know, for women, that's a very different experience where, you know, we are looking to get the A by, you know, the external validation, by the promotion, by something versus the internal validation. And it took me time to really learn that. One, to redefine what A means. Does, you know, A needs to mean that I'm following my personal mission and achieving on my goals. And A needs to be given by me. And so not anything external. For me to be happy and successful in my career, it all needs to happen, you know, based on me really thinking about what I'm trying to achieve. And so I think that's a very different way than I started. You know, in the beginning, is I was like, this is how I got an A in school, and then I'm just going to grind it. I'm going to grind. But grinding only gets you so far. So grinding might get you, you know, from analyst to manager, but as you start to become a leader, there's a, you know, you hit a max. So what got you there, you know, won't get you there, won't get you to the next place. So what got us here won't get us to the next place. And I think at every single level, we have to realize that, you know, now what gets us to the next place is our ability to form relationships and networks and have quality information so that we can synthesize what's going on and really try to drive new ideas and solutions. So, you still got to grind, but it's not just about that. And I think that's a huge transition as you start to, really take on a leadership path.
I mean, that's just such a good reminder that leadership is not only kind of a constant learning and but it's also about reflection and making those active, determinations that you do have to kind of flex what you're thinking about and focusing on in different stages of your career. So that's a really good reminder for all of us. Anu, how do you think about it?
I think it's learning the power of that 3-letter magic word, right? Ask. For me, growing up, that word was yes. And that got me into so much trouble where I did not know the boundaries, or as Christine said, you think you just need to grind. You need to grind extra hard and you have to say yes to everything that comes, and that became like the parameter for how well you perform. And to convert that 3-letter word of yes to ask actually became so much better. So asking for help when needed, asking for what I needed, and not being scared to like put it out there when things were not working. Because I think now the mantra that I actually tell everybody, like all my mentees, I tell them, if you don't ask, the answer is no always. So don't be scared to put it out there. Don't think you have to do this all by yourself. And as a leader, I think that is just the vulnerability aspect. You are so scared early on to show. And when you start like really imbibing the philosophy of like ask, it not only allows you to engage differently, but it also lets the world know that, as women, we say we have to be perfect. We don't have to be. We don't have to know all the answers. We don't have to say yes to everything. We can ask for what is needed when is needed to make our lives better and allow us to perform and really contribute in the ways that are most meaningful for us as individuals and for us as team players and for us as leaders. So it's just changing that 3-letter word from yes to ask. I think that probably was the biggest learning I had to do along my career trajectory.
Yeah, I love that. Well, so typically we close with kind of asking our signature, what would be the title of your book? But I can't help myself. I'm going to have to suggest one for the three of you. I really think you guys are like this trailblazing trio that is just really challenging the status quo and really shaking things up. So thank you for all the work that you're doing. I guess let's close with a final question, which is, what are you each most excited about as you think about the next 10 years of healthcare?
We are in a very exciting phase, right? Like what healthcare has been traditionally, or all the things that we talk about where it lags, right? I think that's all changing. And there's a lot of impetus from consumers, patients, and the innovation that is happening to really challenge that status quo. And for long, we've been an industry that had to do because of ABC. And now we are on a verge to become an industry, much like others, where consumers are asking for things that they want and we get to deliver them. So we are also moving away from we can't do this because of the payer preferences and things. There's a lot more room to try different things, to meet patients differently, to engage them differently, to serve them differently, and to care from them differently. And I'm personally really, really excited about the health equity dialogue that we are having right now, because that I think is going to fundamentally change the way healthcare is delivered in the coming months to years. And to be a part of that change and to play, a very minor role in that trajectory is super exciting. And so I'm excited for where healthcare is leading, and I'm excited about the part our team and our organization, CommonSpirit, will be playing in that trajectory. So lots of exciting things to look forward to.
Absolutely. Manoja, I'm curious, with your scientist first hat, how are you thinking about it?
That in 10 years that we are able to give the right care to the right person at the right time in the right place, and that we can do that for all people.
Very well said. And Christine?
I feel like in healthcare, we now have the right tools to make a real dent when it comes to health disparities. Before, we didn't have the tools. We had all these disparate pieces. So we have no excuse. We have the tools now. And so do we have the ability to work together, to collaborate, to advocate for the right policies so that things can be, so things can come together so that we can actually do it. I'm hopeful for that. I think we can make a huge dent over the next 10 years.
Well, I think with the three of you leading the charge in the realm that you're in, I'm very optimistic that we'll get there. So Manoja, Christine, Anu, thank you so much for spending some time with me today. Really enjoyed the conversation, and thank you for challenging the status quo.
Thank you.
Thanks, Angela.
Thank
you
you
for having us.